Okay, guys, we're going to share a new topic today, and it's a little off uh, the beaten path in terms of what we're doing. Normally, we're doing optics and lens design in prisms and those types of things. But in this case, we're going to do something, and we did laws, legalities, those types of things. But now we just had uh, in spring of 2022, we just had the private practice folks come down, and they were talking about Davis Vision and uh, Medicaid, and they were talking about credentialing and things to that effect. And it occurred to me, I don't know how much you've had in the business management course, the opticianry business management course, but since we're getting to the end of the program, if you decided you're going to go on your own, or if you're going to be a manager, or if you're going to be dealing with any type of managed care or third-party payer, an insurance company, vision plan, those types of things. I want to make sure you have some semblance or a basic idea. We won't be going into actually physically submitting claims to IMED or physically to VSP or physically to Medicaid for this, but I need you to understand the terminology and how it works and have a better idea. So we're going to share this here. And let's do this one. And perfect. So what we're doing now, we'll share application. Hopefully this is sharing properly. We've had some tech issues in terms of recording, but let's try this now. So the basics for billing and coding. I always get a kick out of this because once you graduate, you have your license, you go to the state, you passed your test, you're a Connecticut state licensed optician, and so now everything's wonderful. You can make glasses and buy them and have the patients pay for them or collect their copays. Then you can just apply it to the insurance and they'll give you your money, correct? And the answer is that's not even remotely how easy it is or how it works. There's a whole process. So first you've got to apply for your state opticianry license. Um, Once you get your opticianry license and you can practice, yeah, you can, but you have to obtain malpractice and liability insurance. If you're self-employed, you have to pay for this. Generally, you should be covered under your employer because if you're doing work for them, generally they should have a malpractice and liability insurance. I generally recommend either as an optometrist, optician, anyone should have your own rider or your own personal malpractice or liability insurance. It's not that expensive, but if you get thrown to the wolves, having that extra coverage is always good. But again, you're normally covered under your employer, which is why most of us as opticians don't really worry about that, but it's something to consider, and I could do a whole lecture on that. So you can practice, you're insured, and now you can provide services, but the biggest question is how do you get paid? Um, and first, you need to apply for an MPI, and then you must credential with the insurances. Oftentimes, you must apply for acceptance by an insurance company before they'll allow you to see patients and pay for you to be reimbursed for the services and the products that you provide. Now, the MPI is the National Provider Identifier to credential. If you are credentialed with them and you're accepted onto their quote unquote panel, that means you're in network. There is the possibility in many insurances to provide services where the patients pay out of pocket. You give them the information and the receipts, and then they can apply as an out of network benefit. Let's say I have, say, IMED, and I pay you $600 for frames, lenses, anti-reflective. Oftentimes there may be a VSP does it as well, out of network plan where they'll still give you some money for what you purchased, but oftentimes the benefit isn't quite as great as if you went to one of their participating providers. So that's an interesting little part. In network versus out of network, OON, you'll see that often. It's often easier to bill and be reimbursed if you're in network. That's you become credentialed. You apply to IMED, you apply to VSP, you apply to Medicaid. Some plans will allow a covered member to see anybody who's licensed, and they'll pay out of pocket, then submit a claim, then they'll be reimbursed. But again, the reimbursements or discounts are generally made to encourage you to use their own network of providers. And again, some plans do not allow out-of-network benefits. So if you had maybe a Medicare for post-cataract glasses, my understanding is, and even Medicaid, my understanding is if you buy them somewhere else and submit the receipts, they don't allow you to get their services or products in many of these cases, except through their in-network provider for folks that are already credentialed with them. So what's an MPI? An MPI number is administered by the Centers for Medicare and Medicaid Services, or CMS. There's two types. There's your personal and your group. Your personal is when you apply. I actually have one as a licensed optician. When I owned my own personal practice, both for opticianry and optometry, there was actually a group MPI, and the group MPI is literally just the practice reference number, meaning you should have your own MPI if you're doing private practice, and oftentimes as a professional, most licensed professionals, you can get your own. And then if you're working under a doctor's office or a lens crafter's or something to that effect, a corporate chain, you will have the practice itself will have its own MPI, so they can keep track of who's providing healthcare services across the country. Now, notes you can apply before you're licensed, and you can add locations. If you switch groups, I was an optician to begin with, now an optometrist, it turns out that my MPI number is always going to stay the same. It's just when I changed into an optometry, I actually just added that and changed that so that they know what I was doing. So my personal MPI, once I have it, I'll have it forever. So if you want to apply for your national provider identifier as a licensed optician to become a Medicaid provider or something to that effect, this would be the site that you go to, and it's to the Health and Human Services. And this actually, I use the optometry version, but it also works for opticianry again, and it's simple. The MPI is simply your 10-digit identification number that every healthcare provider in the U.S. is given, and many healthcare plans made to identify you. Again, for HIPAA transactions, yeah, I'll let you go through. And everybody, if you have an MPI number, I can look it up. It is not something that you can withhold. So you can always look up for your MPI. So how to apply? This is the whole thing. You go to the website, you register for the MPI. There you go. I didn't quite want to apply for that, but you'll get the idea. I'll shut that down, and it is what it is. So again, here's the website if you want to apply for your MPI, and off you go to the races. So cool site. Now, once you have an NPI number, oftentimes this is how you would credential. So let's say you want to do your own private practice. Just because you've graduated opticianry or optometry school, just because you've gotten your state license to practice, just because you have malpractice, just because you have an MPI number, if you have your own, and if you practice as a sole proprietor, great. But if you have an LLC or a different practice number, you're going to want an MPI number for there too. Health insurers and discount plans, vision discount plans, are not required to pay or reimburse you for services until you become credentialed. So, what is credentialing? Credentialing is simply the process used by the insurers to make sure that you are who you say you are, that you have the license that you say you do, and that you're able to provide the services or products. Now, this is generally more for your doctors and your surgeons and your ophthalmologists and your nurses, but because you're licensed healthcare professionals, you can in fact get your MPI, and you can in fact credential for some of the vision plans. So they want to make sure you have the right degree, make sure you have the right license, make sure that you're who you are. Just because you have this and you try to, they may not, just because you apply and say, I want to be an IMED provider for glasses only because you can provide glasses, but you can't provide the exam, doesn't mean they'll actually let you in to become an IMED provider. For example, VSP is notoriously pro optometry because it originally started in California for optometrists by optometrists. So generally, they won't let you on the panel unless you can provide both exams and glasses. There are some exceptions, but so for example, as a private optician, you may not make it onto the VSP uh, panel, but you could get Davis as an eyeglass only provider. You likely could do Spectera as an eyeglass provider, you could get iMed as an eyeglass only provider, and that would, if you worked next door to a doctor's office, they could end up signing up for exams. You could sign up doing glasses and contacts to do the hardware, the products, and that may work out for how you do your business. So again, sometimes they'll say our panel is full. Sometimes they will not allow opticians if you're not an optometrist. And interestingly, there's some medical panels that won't allow optometrists on if they're not ophthalmologists. So this is just one of those things where it can be a little on the complex side. Now, health insurance, it's interesting because when we say health insurance, what do we mean? It's a very complex, truly complex system. Now, you have public plans like Medicare and Medicaid. There are private companies, Blue Cross Blue Shield, United Healthcare, WellPoint, Humana, Aetna, UHC, United Healthcare, Cigna, you name it. Well, you can have, I work for the state of Connecticut. We have a private company, Anthem, Blue Cross Blue Shield, but some people are Medicare, some people are Medicaid, and then it turns out in Medicaid in the state of Connecticut, there used to be multiple different strata. You had straight state, which was administered by the state, but at one point, and in many states, they'll farm it out to some of these private companies to administer it, but you are under Medicaid. So it gets very, very, very convoluted at times. So health insurance is generally fee for service. I won't get into this too much here because, again, fee for service or fee for product, meaning you give them something, you prove what you did, they'll pay you a set amount, and if it costs you more to do it, too bad. If you make money in the process, fine. Some of them will have a routine vision benefit for glasses, but not always. Some, like Medicare, will not pay for routine eye exams, but they will pay for medical examinations if you happen to have an eye disease. So if you have glaucoma, if you have cataracts, if you have dry eye, if you have blepharitis, if you have a complaint with flatos and flashes, Medicare will help see you. Medicaid will see you either under office visits or eye exams. Medicare generally will not pay for your eyeglasses except for very few issues. Medicare sometimes will pay for glasses immediately after cataract surgery or sometimes for aphakic patients. Medicaid in the state of Connecticut will pay for glasses. So there are times where it may be worthwhile for you to accept some of these plans as an optician or your practice to take these as an optician because you may get reimbursed something. And whether it makes sense for you financially, that's up to you. There is a difference, in my opinion, between your health insurances, like your Medicaid, Medicare, Blue Cross Blue Shield, and these are, if you get hit by a bus, you get taken care of. If you have a health issue, you get taken care of. If you have routine benefits for eye exams, maybe. A vision discount plan to me is a whole different animal. They didn't exist back in the 80s and almost in the 90s. They were almost unheard of. Most people got their glasses and exams and contacts through self-pay, and these were the outliers. They were unusual. Cash pay was the most common way to get your glasses. Now, most people have some type of a vision plan, vision discount plan, I call it. And these are generally add-ons to your health insurance, but they are not health insurance. Often cover routine services that are not covered by traditional insurers. Again, a lot of these private companies who don't have a separate routine eye exam rider generally won't pay for an exam if there's nothing wrong with you. If you hit by an eye, BB, sure. If you have an eye infection, sure. But if, hey, my eyes are fine and I don't have anything wrong, I want new glasses, many of these don't have that opportunity, which is why vision discount plans like iMed, like VSP were invented to try to get people to get eye care, but also to streamline the process. So VSP, Davis, Spectera, you name it, these are all vision discount plans, as I would call them, or vision plans. I try not to refer to them as vision insurance or health insurance because they are very, very specific, or should be very specific in what it is that they do. And again, like I had mentioned before, in 1999, 48% of eye exams had vision care coverage or vision plan coverage. 2011 at 61%. I will tell you, early 90s was way lower than this, and now in 2020 it's way higher than this. Eyewear, you can see what percentage of people use some type of a vision discount plan, iMed, VSP, on their glasses. It has really increased over time. So for credentialing, you can, I won't get into this part because this is a little bit beyond the scope of what I'd like to get into, but you can contact iMed specifically, you can contact VSP specifically, you can contact Medicare specifically, and that's normally how I would do it for you guys as opticians. For a doctor who may be trying to get into Blue Cross, United Healthcare, Cigna, um, uh, everybody under the sun, Medicare, Medicaid, you name it, there is actually a resource called CAQH, and this is a way that a doctor can apply to one place for their whole credentialing, and here's what my education is, here's what my schooling was, here's my license number, here's my malpractice, and then all the health insurances will find this one and go on the same application. For opticianry, I don't think this is too important for you guys, but just be aware if it becomes where you're going to apply to a bunch, or if you're working with doctors to credential them for your office and you're partners with them, there instead of applying to 20 different insurance companies, you can apply to one and then give all those insurance companies the permission to go straight to this central clearinghouse. And their website is right here, and I'll give you the opportunity to take a look at that. Again, there's a lot of this is both eyewear, optometry, and opticianry. I'm not going to worry too much about this CAQH because I don't think you as opticians will use it too much, but be aware there is a central clearinghouse for you to apply. There is potentially something for vision plans where you can sign up if you want to get onto a lot of these. But if you're only going to take one or two, I would probably suggest as an optician you apply for each one individually. And again, try to figure out which one is which and which one you want to do. Now, all that's great. Let's say you are finally licensed and you have your MPI and you have your insurance, and now you're actually credentialed for, say, a Medicaid. Now, what are all the terms? How does it all work? So today what we're going to do is just a real down to earth basic overview of what billing and what coding really means. So the object for today's lecture is just introduce it as it relates to eye care. So you have to know how to code an eye exam or for glasses or for what you're providing for you to get paid, because whether you work for yourself and you own your own optical practice, whether you work for someone else and you do your billing, whether your optometrists work for you and with you, and again, very rudimentary, but medical coding is a way for us to communicate with a very simplistic, not simplistic, very comprehensive way to say, hey, what did you do for the services or procedures or equipment, and make it so that there's a way we can actually do it instead of writing out, I did an eye exam. Well, what's an eye exam? I did eyeglasses. Well, what do you mean glasses? Frames, lenses, prescription, material. How do I break it down? So it's like putting it down in a very specific way. Let me actually see if I can stop sharing. I'll share this one, do the whole screen. Here's this article. I think I'm going to skip this if you don't mind. Let me just do this. Display settings. There we go. So the coding is we break it down into here's what I did or here's what I gave them. And then the billing is the actual submitting the claim to that vision plan or to the medical insurance and saying, hey, I provided the service or these goods or these products to a patient, and you will reimburse me for those based on our agreement, our contract at a contracted rate. Because if you don't tell them what you did, and if you don't tell them how much it was, and you don't have an agreement, you may not get paid at all, or there may be confusion on how much or how little you get paid. So again, I like to break it down literally as simple as I can. One, what did you do, or what did you give them? Why did you do it? Like, what was the reason? and how much are you charging? It's really as simple as that. What did you do? I gave them frames and lenses. Why did you do that? There has to be a diagnosis for them to need it. They were myopic. They were presbyopic. They have astigmatism. And then how much are you charging? Well, it was this much for the frame, this much for the lenses, this much for the bifocal. Here's how severe the prescription was, and you put it all there, and oftentimes they'll give you an amount of money back based on what you gave them. So this is an electronic health records. Um, and what's interesting here is this is pretty straightforward, but it looks really scary. So we're going to go the eye exam route, not the glasses quite yet, but we're going to go to the eye exam route. And you would see this whole form and say, oh my goodness, this looks really complicated. And why is my head about to explode? But it's actually a little easier than it looks. There's three things you're looking at. It's what did you do? Why did you do it? So here, this was a doctor's office, and they said, hey, we did an eye exam for them. This is an eye exam for doctors. We did some extra testing. We did a refraction. We figured out what their eyeglass prescription was. So, and then why did they come to see us in the first place? Double vision, presbyopia. You get the idea, and we'll say, hey, here's what we did. We saw an exam. We did extra cool tests. This is why we did it. And look at this diagnosis, H53.2. We did a visual field for them to test neurologically what was going on. We saw them for an eye exam or an eye office visit. We did a refraction and see this diagnosis H52.4. H52.4. In this case, we did the refraction based on why they came. So as you start to say, here's what we did, here's why we did it, and what did we do? Why did we do it? So what do? We use what are called CPT codes, or current procedural terminology codes, and they're generally 5-digit codes. And there are, for doctors, we'll skip all this, because if you notice, if you went to your actual eye doctor or even a regular doctor, you went to your primary care doctor, they're going to say, hey, are you a new patient or an existing patient? And was it an easy visit or was it a hard visit? And based upon these, they'll actually say, I was a new patient and it was a relatively straightforward, or I'm an existing patient and they got hit by a bus or poked in the eye or what have you. This is, again, if you're in an optometrist's office, very, very important for you to pay attention to. And each of these this will pay the most, this will pay the least. And again, there's a whole series of these here. So you have to this is really, really, really why it's important if you're working with a doctor or if you're doing any of the coding and billing yourselves, that if you're doing any of this for the exam or the office visits or the testing, you never want to underbill because you're going to lose money. You never want to overbill because that's against the law and it's fraud. But the same idea happens with opticianry. So we skipped that last slide, but this is it. What did you do, or what did you provide? What services or goods? And how about for us, for eyewear? We use what's called a HCPCS, and this is a series of codes for eye care. So frames, V2020 or V2025. This is the code to let them know that we gave them an ophthalmic frame, or in this case, a deluxe ophthalmic frame. Here I just use V2020 all the time. Well, there's a whole series of V codes or HCPCS codes, V2100 to V2199 are all the various codes for single vision lenses. V2200 to V2299 are all bifocal lenses, and V2300 to 2399, I should say, are for trifocal lenses, and then add-ons, dispensing fee, and I'll get into that in a second. All right, so it's not letting me have that, so that's okay. So let's get I'll give you some forms to look up these, but if you got to the point, let me see if I can't find one. All right, sorry about that. I had to find this little sheet here. So I'll share some of these with you, but if you're to look at your spectacle frames, here are your two codes. So if you did an eyeglass ophthalmic frame, you get V2020 is your HCPCS code. And V2025 is a deluxe frame. I'm not getting into the nuances of that. But what's really cool is look at all my single vision lenses. And single vision lenses, V2100, is my code for a sphere, single vision, plano to plus or minus 4 per lens. V2101, well, it's still a sphere, it's still single vision, but it's a higher prescription. It's over 4, but up to 7. V2102, plus or minus single vision, over 7, up to 20. Well, notice how, based on the type of lens, let's say it's sphere cylindrical, 4 sil with a 4 diopter, up to 4 diopter with up to 2 diopters of sil. Well, up to 4 with up to 4 diopters of sil, up to 4 with 6 diopters of sil. Notice how, over 6 diopters, notice how there are different ways for us to categorize every single lens that we have that's single vision, and there'll be one code for the right eye, one code for the left eye, and they both could be the same. They both could be a -2 sphere. Well, they would both be a V2100. And so now, same thing, you could classify every straight top code based on how strong the prescription and how much sil it is, every trifocal, and there's a whole bunch of other things here that this is how you would figure out if you gave them -2 with a -2 sil, single vision. Let's do -2 with a -2 sil for a bifocal with a 225 add. A -2 with a -2 sil would be V2203, and I did 2 of them, one for the right, one for the left. And that's how we would figure out what code we're using for what lens. Let's go back to our little codes. So let's go back to this one. So, and again, if it has 21, V21 with any other modifiers, it's a single vision. V22, it's a bifocal. V23, it's a trifocal specifically. And there's also for Medicaid in the state of Connecticut, there's a V5160. It's the dispensing fee, the dispensing, the adjusting, the fitting, the measuring, all that other stuff. And there's an additional fee that you can get paid for. If you leave that off, you're leaving money on the table. If you made the glasses and gave them to them, well, you're entitled to that dispensing fee. So there's the frame, the lenses, and at least in Connecticut Medicare, there's a dispensing fee that you don't leave on the table. How about contact lenses? The contact lens fitting, you would have a contact lens fitting code. 92310 is my CPT code. And you can do scleral lenses and aphakic lenses. There's other codes that we can look up here, but here's what you did. And then if you're selling the contacts, notice how it's V25. If it's a V25 code, that means it's contact lenses. So take a look. Single vision, V21, bifocals, V22, trifocals, V23, contacts, V25. So you start to see patterns here, and after a while, when you start seeing them, it all becomes second nature. And again, what do we do if you're doing office visits? You do 99 or 92 codes, but we're not going to get into that. But again, the frames, the lenses, the bifocals, the contact lenses, the contact lens fittings, that's what we did. And then why did you did it? Well, you have to have a reason. We use what's called an ICD-10, the International Classification of Disease 10th edition. And what it'll do is it gives us all sorts of codes on what we, now if you can imagine, literally anything you could possibly have, diseases of the eye or neck. So this is great for eye exams, but what we're going to do primarily is generally these refractive errors. The only ones that you're generally going to bill for are these here. I have hyperopia, or as they call it, hypermetropia. I have myopia, astigmatism, irregular if you're doing contacts, regular astigmatism, which is very common. You can have aniso, you can have presbyopia, and these are pretty much the ones that we are going to deal with as opticians when it comes to ICD-10 codes. So if you're to look, if they had hyperopia in both eyes, and it was a +3 with a 2 sil, with a 250 ad, well, they're hyperopic in each eye. They have astigmatism, regular astigmatism in each eye, and they are presbyopia. So you'd actually have 3 kits. So if you had a +2, -2, let's do -1, axis 180, and that was the right eye, and this was the left eye, and then they add so 2.25. I would argue that they both had hyper. So H52 is the base, the primary, and then H52.0 means hyperopia. And then you can either say unspecified eye. I'm not sure why you ever use that, but just in the right, just in the left, or bilateral. So this person would have H52.03, which is presbyopia, sorry, hyperopia in both eyes. And then you would have astigmatism in both eyes, and it would be regular astigmatism bilaterally. And you'd have H52.4, which is presbyopia. And there is no modifier for right or left because it's always OU. So if you had this patient here and you're filling out a insurance claim, the reason why you gave them glasses, the reason why you gave them progressives, the reason why you gave them straight tops, the reason why you gave them an eyeglass frame was H5203, H52223, and H52.4. I would be able to tell the insurance company knows that they're hypermetropic or hyperopic, they are astigmatic, and they have presbyopia, and this is our system. And whether you have cancer or brain cancer or high blood pressure or diabetes or eye infections or anything, everything that could happen to the human body pretty much has an ICD-10 code, and these are all the ones that we'll use, as far as I'm concerned, for opticianry. So let's go back to our little PowerPoint there. And let's get rid of this one. All right, so why did you do it? Those are the ICD-10 codes. And again, we used to have the refractive codes, and here you go. This is the same thing. The types of codes that we're going to use an awful lot of are myopia, hyperopia, H52.01, H52.02, H52.103, farsighted in the right, farsighted in the left, or farsighted in both, myopic in the right or the left or both, H52.11, astigmatism, right and left. And again, notice how all the codes are H52 point something, and then presbyopia should be H52.4 if I'm not mistaken. In this code, it says H52.7, but it should be 52.4. I'll double check that. And then finally, what did you do? Gave them eyeglasses or frames and lenses. V2020 for the frame, V2100 for -1 spheres OU. Why did I do it? They were myopic in both eyes, H52.13, and the claim would reflect that. And then the question is how much you're charging. And this is very important. You have to be consistent in terms of how much you charge. If you're an eye doctor, you can't charge one insurance company more than another for the exact same thing that you're doing. They can pay you less, but you have to charge everybody the same. And again, third-party players will only pay up to a certain amount for any particular service. So if you said, hey, I'm going to give you glasses through Medicaid, you can say they cost $400 for the frame and $800 for the lenses, and that's fine. You can charge $1,200, but generally they're only going to give you their contracted amount, which let's say for Medicaid in Connecticut, the frame may be $29.92. Well, it doesn't matter that you would charge somebody $400 for it. They will pay you a certain amount and no more, period. That's how it works. Now, by the same token, if you charge less, they'll only pay what you ask for. So that may fit into how you charge or how you set your prices to make sure that you don't leave any money on the table as a business owner or as an optician or as a manager. So let's say it was a V. This says if Blue Cross Blue Shield pays a maximum of $134 for an eye exam, and you charge $169, you can charge more. They'll give you $134 for the 169, but no more. But if you only charge 100 and they pay up to 134, they're not going to pay the full 134. They're only charge what you ask them for. Same thing for a frame. If they pay $29 for a frame and you charge them $200, they're only going to pay you $29. If you charge them $20 and they pay up to $29, they're only going to pay you the $20. So you should at least take this into account when you set your prices. So again, vision care plans. What is important to do for your vision care plans? Look up eligibility. I can't tell you how many quadrillions of times I've seen this for patients. They'll say, I have a vision plan and I have iMed and I haven't used it this year. Well, you can't just take their word for it or what they think. You have to go onto their website with your provider ID through a portal. You have to get their information, and a lot of times it's their social security number, name, date of birth, which version. Has it been used once already? Are they still eligible? Do you need an authorization? Some people have it and they'll have iMed or VSP or something to that effect. And you do all the money, you do all the glasses and the frames. But then when you submit it, they're like, hey, you didn't take that extra step of reserving their benefit. So you're essentially saying, I know they have a benefit, and an authorization is, I plan on using this as their eye care provider. We're going to reserve this benefit so no one else can use it, and we're going to submit it and you should pay it. If you have an authorization, you don't bill it, you won't get paid. If you bill it and you don't have an authorization, sometimes you won't get paid. So it's very, very important. So again, different vision care discounts equal different benefits. An iMed plan is not an iMed plan is not an iMed plan. Different versions of the same plan may have different reimbursements. Sometimes they'll pay $120 for a frame for iMed. Some they'll pay $95 for a frame for iMed. Sometimes they won't pay anything, but they'll mandate that you give them a 40% discount for iMed. So you have to be very, very careful, not what you think or what you're used to or what the patient thinks. Very carefully comb through the documents when you get an authorization, when you look at the benefits, make sure you're calculating these correctly. And I can't tell you how many times patients will misunderstand what they think they're entitled to. And a lot of them are, oh, I get glasses and contacts. Well, many vision plans will cover glasses or contacts. Some will say, everything I want is free and I have no out-of-pocket costs, when in fact, they don't, and they may have a good benefit, but oftentimes they will be on the hook for $300 or $400 after their insurance, and they were under the impression they would have no out-of-pocket cost. Or I get free upgrades, I get free AR, free transitions, free progressives, when in fact, that's not the case. Does the plan renew every calendar year? Well, sometimes it's 1 year from when you used it. Other times it resets on January 1st. Sometimes it's every 2 years, so you have to watch out for that. I've seen some plans where it resets on January 1st every year. Excuse me. So if you used it on December 20th, that was your first time in that year. And then at January 1st, you're eligible again. Well, January 1st, you can get another pair, but you can't get another pair until the following year. Other times it's 12 months from the date of service. So again, there's so many differences that you must not take the patient's word for it. Don't think you know how it all works. It could change on a dime unless you have the printout, unless you have the verification in your hands. I would not guarantee or plan on anything until you see it in writing. Now, again, it's important to obtain an authorization. Some of the vision care plans will require you to reserve that benefit. And one of the benefits for that is if a patient was not being above board or they were not being honest, they may go to your office, get a pair of glasses, say they have the benefit, you pull the benefit, you pay for the glasses, you give them the glasses, you bill, and then they did it to 5 other places. There's almost no way to figure that out. So oftentimes you will get the information from the patient with their name, date of birth, and you will say, I'm planning on using this benefit for this patient, and you will reserve it, which is good because now you know that you'll get paid if you follow through, but it's also good so that they don't go somewhere else and try to double dip. Now, if they opt not to get the glasses from you and then they go elsewhere and they really want to get it from somewhere else, you still have the authorization. That can sometimes be a hassle. So make sure if they're not getting it from you that you just release that authorization or release that reservation. But again, you may need that reservation or that authorization. Quick notes, vision insurance versus medical insurance. Like I said, I don't believe that vision discount plans should be referred to as insurance. They're vision plans specifically to reduce the cost, but insurance for me is a different animal that covers when you're sick and it has more to do with medicine. Vision insurance is more just to reduce the cost of our the products. I oftentimes, especially when you're in a medical office, they will say, hey, I have IMED and I have Blue Cross Blue Shield and I have a free exam through my IMED, but if I use my Blue Cross Blue Shield, it's a $100 deductible and a $20 copay. Well, if they're coming in and they're diabetic, the vision insurance is primarily used when there's no problems, there's no complaints outside of I just need new eyeglasses and everything else is fine. Otherwise, generally, I would recommend that your office refer to the medical insurance as the primary. And so if your doctor is seeing a diabetic or glaucoma suspect or somebody who's got reduced vision for double vision or fluorescent flashes or cataract, it is inappropriate, in my opinion, to use the vision discount plan. They should be using their medical insurance for that. The vision insurance is just for the, hey, everything's fine in absence of any pathology or complaints or diseases. And I just want to get my eyes checked to make sure nothing is bad happening. But if there's potentially something bad happening, then the medical insurance should be billed. And if you have a doctor that does it that way, please understand that's why they do it. I only want what my insurance covers. I don't like that as an optician. If somebody I would never sell a pair of glasses that didn't have anti-reflective. I would never sell a cheap anti-reflective. I think progressive lens technology has come a long way. So picking a better technology or a better quality design may be in your patient's best interest. And oftentimes they say, hey, I get a free pair of glasses, but they're cheap and it's a low amount of reimbursement. I sometimes look at it in a different way. And I'll say, listen, here's what I would get you if you had no insurance and nothing, no other way to pay for it. Here's the frame, it's 250. Here's the lenses, the index, the transitions, the anti-reflective, and this is what I would get you, period, no matter what. And this would be, say, argue it's an $850 pair of glasses. Your insurance will cover part of it, discount some of it, and you're left with a $300 balance. And the way I generally try to address it to them is, here's an $850 pair of glasses that you're getting for $300. You have a $500 benefit from your vision discount plan. This is a big benefit for you and it gets you what you need and it's worth it because you're going to have them every day. Some people say, I just want my insurance covers. It's a $100 pair of glasses that they got for free, but it's not got the bells and whistles and the technology and the benefits that it needs. Try to avoid that. I only want what my insurance covers. And there's a way to sell around those objections to get them what they need and what they deserve. And if they have an insurance vision discount plan, you can get it for a substantial savings over what it would cost without insurance. Again, this is the issue. If you work for LensCrafters, Walmart, private practice, every plan, you have to go to IMED's website. You have to go to VSP's website. You have to go to Spectera's website. You have to go to Davis's website. You may have multiple different EHRs, electronic health records. Each company has a different way to plan or bill or order. So you're going to have to sort of go through their training to see how they do it in particularly. But this is very, very important to understand. This is an old-fashioned HCFA form, the health insurance claim form. We used to physically type these all out or write them all out and put all of our names, addresses, the insurance information, have the patient sign, and then we do the diagnosis codes right here. There's your myopia, and then when we did the service, and there would be my V2020, and I charge $100, and my V21, what date I have, my V2100, my two spherical lenses, how much I charged, all my name. I'd send it via mail or fax, and they would send me a check. Well, we don't do that anymore. Now we do it all via the electronic health records now. And again, why do we do what we do? What did we do? How much did it cost? And so I think I'll leave it at there. Here it's a pretty interesting subject, but I do know some of you at some point may want to do some private practice or open your own practice. And this is why I put this lecture together, because some of you looked at it and said, hey, I don't even know where to start. Well, there's a lot of information here, and I do want to give you just a heads up so you can talk the language, so you can understand the lingo and essentially what it is we're trying to do. And let's see if we can't give you a little bit more information above and beyond so that you're more comfortable with it. So be that as it may, I'm going to end it there, and I'll share a couple of these specifically as in homework, just so you can parse through them so you can get an idea. But again, a lot of this is from each individual store, how your electronic health records installs it. But hopefully this is going to give you a little bit of information and helps a little bit to help you understand the process a little bit better. All right. Thank you much. Talk to you in a bit.